Heart failure affects millions of people worldwide, but over 50% of those cases now belong to a specific category: heart failure with preserved ejection fraction, or HFpEF. These patients experience severe shortness of breath and fluid congestion, yet standard imaging shows the heart's main pumping function, the ejection fraction, is 50% or higher. This chart shows the incidence of heart failure over the last decade. While other forms of the disease are stabilizing, HFpEF cases are rising. These patients experience morbidity and hospitalization rates comparable to those with reduced ejection fraction, leading to substantial resource utilization across the healthcare system. The medical community is currently managing a growing epidemic that remains difficult to identify because the most common cardiac metrics appear healthy. The difficulty in identifying the disease stems from a lack of a single definitive test to confirm a diagnosis. Standard biomarkers like natriuretic peptides can be misleading. In patients with HFpEF, these levels often register as normal, especially in individuals with obesity or insulin resistance, even when cardiac filling pressures are dangerously high. Clinicians use the H2FpEF score, calculating probability from 6 variables: body mass index, multiple blood pressure medications, atrial fibrillation, pulmonary hypertension, age over 60, and elevated filling pressures. Scores of 6 or higher strongly suggest HFpEF. Intermediate scores require advanced testing, like invasive hemodynamics. Establishing a diagnosis requires clinical deduction that accounts for the limitations of isolated test results. Clinical deduction also involves ruling out mimics, distinct conditions that cause the same shortness of breath and swelling as heart failure. This tree separates symptoms into non-cardiac causes. Pulmonary disease, chronic kidney disease, or severe anemia drive fluid retention without primary heart failure. The cardiac pathway reveals structural mimics. Diseases like cardiac amyloidosis or valvular issues present with preserved ejection fraction but require different treatments. The stakes of this differentiation are high. Using standard heart failure therapies to treat a mimic prevents the patient from receiving the specific care their true condition requires. A confirmed diagnosis requires a systematic exclusion of both non-cardiac and structural cardiac mimics. Cardiology currently defines HFpEF as a systemic cardiovascular kidney metabolic syndrome. This diagram illustrates how visceral adiposity releases inflammatory proteins, stiffening the vascular system. The clustering of obesity, type 2 diabetes, and chronic kidney disease creates a cycle where dysfunction in one organ amplifies injury in others, raising hospitalization risk by 57%. Because the disease is systemic, effective management targets the interconnected metabolic web rather than just the heart muscle. While effective treatments were historically limited, clinical trials over the last decade have identified several classes of medication that alter the course of the disease. This matrix maps primary HFpEF therapies. SGLT2 inhibitors significantly reduce heart failure hospitalizations and cardiovascular death. Non-steroidal mineralocorticoid receptor antagonists, like finerenone, reduce worsening events and protect kidney function. Incretin-based therapies, like semaglutide or tirzepatide, yield substantial weight loss and improve physical exercise capacity. Clinical care has transitioned to targeting the underlying metabolic and inflammatory drivers of the syndrome.